Hey guys, welcome to Man Medicine, where we talk about how men can optimize their health and escape the collapsing U.S. healthcare system, and in this case, the collapsing UK healthcare system. I'm honored to have my friend and colleague, Dr. Max Draper from Alphagenix, here with me today, and we're going to have a little kind of a free-flowing discussion about estradiol, aromatase inhibitors, and really whatever else comes up in that area. Maybe we'll dispel a few myths. We'll probably upset a few people, as we typically do with this topic. It's kind of contentious, isn't it?
Oh
Aromatase
yeah.
inhibitors and estradiol in the world of TRT and men's health and hormone replacement. Why do you think that is? I have my own thoughts about it, but there's some people that get, especially online, get very upset about this subject for some reason on one side or the other. It's very polarized, right?
Yeah, it's almost like political debate nowadays, isn't it,
It,
really? It's become very much either you're pro AI or you're anti AI.
right, right.
I'm not quite sure why it's so emotionally charged as such. I think a
Hmm.
lot of us are just trying to explain the science behind what we advise, but yeah, it
Hmm.
certainly does get a lot of attention online for sure. I think
Yeah.
because I suppose people like you and I are seen as quite dogmatic about it. I
Hmm.
guess I don't know if that's the right
Maybe.
terminology, and people
Yeah.
don't like that sort of that viewpoint. I guess, but I'm not
I
sure.
suppose so. Yeah. And I try not to be dogmatic about most things because, you and I have both been practicing long enough to see the winds of change in medicine, where things that we were certain were correct are now have we found out that they're actually incorrect. And when I very first started dabbling in this area and started learning about testosterone replacement therapy and men's health, it was well over a decade ago. It was sort of just generally accepted that that's what you did is you started men on some sort of a estrogen modulating agent. Usually it was obviously anastrozole in the US is the most common one. I think, is that still the most common one over there in the UK?
Yeah,
And
yeah,
exemestane, and then,
yeah.
and then you start seeing other, you see some people like to throw serums in there now, and you'll see other agents. But yeah, anastrozole, it was just sort of the thing that right out of the gate you would just start a man on. And in fact, when I first started on testosterone, I I was on an AI, and
Hmm.
like just about everybody else. And then, as time goes on, you learn new things, new research comes out, you get better educated, and then you start making modifications to that. But it's still there, and there's still a lot of I still get patients that come to me that are on AIs, and sometimes it's sort of dubious why they were put on them in the first place. So
Yeah, yeah. I think because I came to the game a bit later than you, I think there was already that kind of push against the at least the routine use of AIs by the time
right.
I started learning about this.
Yeah.
And I came across, people like Dr. Jordan Grant
Yeah.
online
Yeah.
and his sort of
Hmm.
case against using them. I still remember though when I started TRT, my estradiol went outside of the normal range, and I still had that moment where I was
Right.
like, "Oh, is that okay?" Even though I'd read about it and learned about it, it still kind of gave me that little hint of anxiety there. But yeah, times change, don't they? As well, it's
Hmm.
like you said. Here, I would say of the transfers from other clinics, I would say I see about a third of guys on an AI.
Yeah.
So it's still quite a high proportion
Hmm.
come to see me, and they're on exemestane or anastrozole. Those two are the common ones
Hmm.
I do see over here as well. Yeah,
Yeah, and the most common reason I always ask, why did your doctor put you on this? And the universal answer is, well, my levels were high. My
yeah,
estradiol level was high. So, not only the patient but the provider, just like you did, and I did too initially. When you see that number in red, you're like, oh,
hmm,
that's we're trained right in medical school. If it's that number's in red, or if there's a capital letter H or L by it, then that's a problem, and we have to
yeah,
address that. Not fully understanding that, obviously the general male reference ranges that come from these population based studies obviously did not include, first of all, young, fit, healthy men most of the time, and they also didn't include men who were on therapeutic testosterone replacement. So we're not even using reference ranges that necessarily apply to guys like ourselves or like our patients. But
yeah.
it's seeing that color in red, and you'll see it on the forums too. Guys will post their labs, and they'll be like, "What should I do?" And, you'll see a serum estradiol, in our units here, it'll be 50 or 60, picograms per ml, which I don't know, you have to do the math for, you guys use picomoles.
Yeah.
But
Not
over
too
90, over
Yeah.
100,
Yeah.
and it generates a lot of anxiety, and that's
Yeah.
it's a problem. But when I ask them, were you having a particular side effect or some sort of a symptom? The answer most of the time is no. Or I'll
Yeah.
occasionally hear, I was fatigued, or I was having trouble losing weight, or I had water retention is one. And so maybe we can comment on that, because that's a little bit of fluctuations in fluid balance are not uncommon, aren't they? Like in the first month or so when you first start on testosterone. I think I even had some watery ankles, for a little while. But I think that is one of the major triggers that causes a provider to throw an AI on there. And the concerning thing about that is a lot of times when these AIs, when they get started, they never get stopped. They just, it just becomes part of the protocol. And well, I need this because if I stop it, all that fluid will come back.
Yeah.
Right.
Well, I think the first point as well that you said was that when your lab level comes back as red, I think that number one point is, remember, these lab levels aren't designed for guys on TRT.
Precisely.
And with my work, the panels we do always include an estradiol. And I know that even like a lot of guys your way now don't even monitor it, which I think is completely logical.
Right.
But I tell you, when a guy's on TRT, they've got good levels of testosterone. I never see an estradiol in the normal range, the normal range.
Right.
Very
very rarely.
Very rarely are they going to come back in the normal range, and that's completely expected. So we don't need to worry about it coming back in red. But yeah, secondly, what I hear is very similar to yours. So they might have had some sensitive nipples at the start of treatment.
Precisely. Yeah.
They might have complained of some sort of mood fluctuations, or like you said, fluid changes or fluid retention. And I think a lot of those initial, let's say, side effects of TRT will often just settle with time by themselves.
They do.
Always do.
Almost always. Almost always. Yeah. Yeah, if there's this activation of the renin-angiotensin system, you do get this sudden surge in estradiol, which is that person may not be accustomed to that, and if I remember my physiology correctly, you get some increased sensitivity to antidiuretic hormone with that surge in estradiol that comes in those first few weeks. But you're right, it's the renin-angiotensin system. It's an adaptive system. It's designed to change over time, and it compensates for that. And if you can just sort of wait it out a little bit, those fluid dynamics, those fluid shifts will generally settle themselves out. And quite honestly, I think they respond better to an ACE inhibitor or an ARB. If you're going to do something for 30 days just to manage it, certainly an astrazole, it will lower the estradiol. And so indirectly, it will help with the fluid. But really, an ACE or an ARB, which obviously has far better health benefits for many men than an AI, in my opinion, works just as well, if not better. So, I mean, I might just throw them on a little bit of lisinopril or telmisartan for a little while. And I would actually generally feel better about continuing that into perpetuity than an AI, because at least we know that there's some potential health benefits for those drugs. So,
well, I was going to say, probably the polar opposite in terms of what you know about anastrozole long-term outcomes for cardiovascular health. If you used an ARB and an ACE inhibitor, you're actually you're potentially benefiting their long-term heart health.
Yeah, precisely. So, and there are guys out there that feel very strongly about this, and I'll just say, we're not here to bash you. If you really feel like you need to be on an AI, I think by all means you can stay on your AI, but I think you just should understand the risks that you're taking, understand if there are potential benefits. Testosterone therapy is meant to be lifelong therapy. And so if you feel like you need an AI, then definitely you have to realize that you are potentially going to be on an AI. If you're 40 years old, you might, and you would like to live to 90, are you willing to commit to taking an AI multiple times or once, whatever the protocol is, per week for the next 50 years. And is that really in your best interest? Well, I think it's important to recognize up front. I think, you and I both, we try to be evidence-based providers as much as possible. I certainly do, not just in my men's health practice, but, my hospital practice too. We try to follow the evidence. Having said that, there's a huge part of TRT where the studies haven't been done. So we do the best that we can. And we'll in the course of this talk, maybe talk about some of the studies that were done in men with prostate cancer and other situations that aren't quite the same as what we're dealing with TRT, but that's the best that we have. So having said that, we have to realize that all of these studies which show benefit from TRT, of which there are many, none of them were with an AI, were they? In the way that it's being used, I should say. Some of them do have AIs, but they're not. The protocols for these studies are not what we typically see in the men's health world, where for long periods of time you're blocking the aromatase enzyme. And so, these studies that show benefit, none of them were with an AI. So if you're going to use an AI chronically, if you're a provider and you are going to prescribe them, and I'm not putting judgment on you one way or the other, you just have to realize you're not really practicing evidence-based medicine, are you?
You're a little bit you're going into the unknown, and what I would add to that is kind of what we do know about the use of AIs. Let's say in breast cancer, in women who've had breast cancer, let's say, is although the doses will often be higher in those scenarios, i.e., they'll be on maybe 1 milligram a day. I think it's a commonly used. But their health outcomes, from the AI use aren't that reassuring in terms of
you're being diplomatic about it. They're terrible, right? They're all dying. They're dying of cardiovascular disease. It's like, congratulations, you survived your cancer, but the STEMI got you, or the stroke, or whatever the case may be. The hip fracture.
It's heart disease, it's strokes, it's even it impacts, there's studies out there showing that the impact on mental health, mood disturbances with AIs in these women, cognitive function. So they've looked at anastrozol's use and followed the women up at sort of 6 months and beyond. And even very quickly on anastrozol, their cognitive functioning actually deteriorates or at least drops down fairly statistically significantly. And if you elongate that out, like you said, so these women will have a set point at which they come off the AI based on the breast cancer. But if these guys, exactly like you said, if you're wedded to your AI, so you're going to be on it for 10, 20, 30 years potentially, the evidence we do have of AI's use in these women for 1, 2, 3, 4, 5 years is not very nice looking. So even if the dose is lower, if you look at the way these drugs work, you wouldn't be very confident. I certainly wouldn't be being confident about taking one long term.
Right. Exactly. And the argument on the other side will be, well, we don't have data on men who are using them in the way that they're being used today. But you're right. We can extrapolate to a certain extent. And one thing I think is important to say is that there is no study that I'm aware of. And if listeners out there, you guys are aware of this and I'm not, please correct me or please share it with me. But there's no study I'm aware of where men were given therapeutic testosterone and an AI that showed superior outcomes to just using testosterone alone. So we don't see increases in bone mineral density. In fact, many of the studies we see a decrease. We don't see improvements in lipid panels. In fact, we see worsening lipid panels. So whatever parameter you want to look at for overall health or longevity, body fat percentage is a big one, in metabolic health, insulin sensitivity. None of those get better with the addition of the AI objectively, based on the data that we have right now. So really, what are okay, maybe we're treating some symptoms. Maybe we're treating anxiety, as in some men. I think that's actually the case. But regardless of what we're doing, we're not adding anything in terms of objective health parameters to a man who's on therapeutic testosterone by also adding an AI. So we're not moving the needle forward in terms of your health overall. And now maybe, there may be people that argue that, but as far as the data that I've seen, as far as actually, well done studies, that they don't exist to my knowledge.
Yeah.
Again, correct me. I don't have time to read every single study that's ever been published on all subjects, but yeah.
Well, similarly, when you use an AI versus just testosterone, you'll see a lack of symptom resolution. So
that's right. Yeah.
You'll actually see that, generally speaking, the studies would, at least the studies that are done in this nature, would suggest that people don't get full symptom resolution when you block the creation of estrogen. So I think what you and I kind of, often chat about is the fact that a lot of the benefits from TRT will be the extra estrogen or estradiol.
That's right.
Yeah,
that's right.
I think, and that includes the health benefits as well as how we feel, because estradiol is important for mood, libido, even it's got a role in nitric oxide production, I believe. So erections, yeah. And then you were going to touch upon the fat cells, how it's important for actual fat loss rather than
there was there's the Finkelstein studies, which were done a number of years ago, which very eloquently showed that. And if we want, since we brought it up, I can kind of run through some of that real quick here with you. I just I took some notes on one of the studies that I thought was particularly good, and I won't go too far in the weeds, guys, I promise, with this one. But actually, I don't know if this wasn't one of Finkelstein's, I think, but this is a different one. It was from the 2014 Journal of Sexual Medicine. And so they did let me put my granny readers on here, 14-week placebo-controlled trial. So they took obese young men aged 24 to 51. So I like that they included 51-year-olds as young. That makes me feel better about myself, at least for one more year. So this is one of these. There's some really great studies out there that have been done in the last 30 years, where the standard protocol is they wipe out the HPTA axis on these volunteers. By the way, I think I had a couple med school classmates that volunteered for these studies back in the late 90s. And all of them, by the way, they all had like 4 or 5 kids already. So they were just like, we don't care. Just like, they put them on Lupron shots, and just wiped out their HPTA axis. And then they would add back testosterone, add back estradiol, add back, an AI, and then, just basically look at all the permutations and try to isolate which symptoms are associated with testosterone, which ones are associated with estradiol, what happens when you block DHT, but you don't block estradiol. So they're fairly complex, but they're just they're beautiful, like elegant studies. So anyway, they had a number of groups. They used T-gel, which obviously is, this 1 or 2% gel is not what you and I would consider to be adequate, but regardless, that's what they used in these studies. So you have to just sort of take that as par for the course. But
that's what I started on. That began my journey.
Yeah, and you got a little bit better, right? You got a little bit.
Yeah, a little bit. Yeah. But I was bathing in it twice a day.
Well, you pretty much have to, I think, to get anything out of that stuff. Anyway, they put these guys on different protocols: T-gel plus an AI, T-gel by itself, T-gel with dutasteride, so they blocked DHT, but then no AI. And then they had a group that was on like a triple placebo. Anyway, long story short, I'll read you the estradiol levels they're going to be in picograms per ml. So do a little bit of mental math. So the guys with T-gel that were just on T-gel, their serum estradiol levels, again, high sensitivity estradiol done with a mass spec, which is a way to do it, 55.29. The guys that were on dutasteride, it was 42 picograms per ml. If you were on T-gel and an AI, it crushed it all the way down to 3.18. So very, very low. And even to be fair, the proponents of AIs today would say that that's too low. They don't recommend, dropping your estradiol that low. And then the triple placebo group, their serum estradiol levels were 20.7. Long story short, the only 2 groups that lost body fat, despite having all the groups that got testosterone had roughly the same T levels, but the only groups that lost body fat percentage were the T-gel alone and the T-gel plus dutasteride group. So the group that got the AI, despite having identical testosterone and identical DHT levels to the T-gel group, they actually gained body fat. They actually gained, well, I apologize. They went from 32.9% to 32.2%. So essentially negligible drop in body fat percentage. And that was about the same as placebo. So if what's interesting about this is, if you start on testosterone replacement therapy and you are obese, which many guys are, one of the reasons most guys want to get on testosterone therapy, and in fact, one of the reasons they're hypogonadal in the first place is because of their obesity, especially their visceral body fat. The use of an AI, at least crushing the estradiol like they did, it completely negated the positive effects of testosterone when it comes to body fat percentage. So it's really it's the opposite of what these guys need. They need to lose body fat percentage, not just for their overall health, and blocking estradiol to the extent that they did not benefit these guys at all. And I know the argument, the AI, the guys that do say, are proponents of AIs are going to be like, well, we don't want, we don't recommend blocking it that low. Obviously, we just want to block it a little bit. But, again, I would say that I would go back to the guys that had the most body fat loss, the best body composition changes occurred in this group between 42 and 55, picograms per ml, which I think in most assays, at least the 55 would trigger a little red H by it. And then that in many cases would prompt a provider to put them on an AI, thereby canceling the beneficial effects on body composition. So,
well, I think what it shows, I think what it shows is, again, something that we will harp on probably fairly frequently is this idea that those fat cells are making estradiol for a reason, and it's actually significant to their metabolism. So your body's smart. If you're carrying a lot of adipose tissue, there's a reason that you'll be converting testosterone in those cells to estradiol. It's because those fat cells kind of want it. It's like where you make it in your bones, in your brain, in other aspects of your health, in your body. Your body wants to make that estrogen for a reason, and so blocking that conversion, even if you do it a little bit, what we should probably touch upon is this idea that cellularly, we don't know how much you're blocking organ by organ in terms of, if you take 1 milligram of an estradiol a week in total, maybe you split that into 2 halves, which I think is quite a common dose over here. I don't know if that's a common dose in the US.
Once a week, half a milligram twice a week, or half. It's all over the map. I do see the doses on the forums, because I always kind of troll around the forums, and the guys that talk about their AIs. I'm seeing, thankfully, lower and lower dosages, so like 0.25 once a week. So these little we're getting towards like homeopathic doses of an estradiol. And that maybe doesn't make a lot of sense with the half-life of the drug anyway, in terms of not really. No.
But what we don't know is, because the serum level is just telling us what's spilt out from the cells. That's right. Basic where it's made. So this is kind of thing we'll touch upon, is the endocrine process. We don't know how much even those low doses of an estradiol is actually depriving those little cells of the estrogen that they want. So I think that's where, the whole dose, although lower is obviously better, we still don't exactly know what goes on at a cellular level in all these organ systems where you want the estrogen.
Right.
And that study just shows you that those fat cells are producing the estradiol for a very logical reason, and it helps you to lose body fat if you let your estrogen run wild.
I've heard it argued that estradiol, that's actually a protective mechanism. That it is actually the body trying to offset the negative effects of the excess body fat percentage. But you bring up a great point. I mean, estradiol it's a little bit different than the classic HPTA axis hormones, where you have signals from the hypothalamus to the pituitary to the end organ, and then the end organ secretes a hormone that then circulates out to the rest of the body. That does happen. However, a lot of it is created locally in the tissues, as you mentioned. And it's not just created in the tissues, but it's also metabolized in the tissues. And so, yeah, what ends up in the bloodstream is maybe you could call it the metabolic leftovers of a local tissue process that, it has a correlation with what's happening, I think, in the tissues, but it's very difficult. It's not as precise as maybe measuring a serum cortisol level, for example, or a prolactin, something like that, where your level is what your level is. And you're right. So we don't, without doing tissue biopsies of the actual tissue locally, you don't always know. And I actually was able to find some studies that, I mean, we won't go too far into this due to time, but where it was in animals where they would measure serum levels of estradiol, and then they would grind up various tissues and find out what the local tissue levels were. And they didn't necessarily correlate that well. I mean, there was a reasonable correlation. If the serum went up, then the tissue level went up, but that ratio can be different from animal to animal. And as far as I know, nobody has done that in humans, to my knowledge. So
no. Well, I think a good organ for people to look at if they do like to learn about this stuff is the prostate gland and DHT, because the nature of what's going on is identical. Essentially, you can see, because the prostate's been studied so much because of prostate cancer, and then and scientists or doctors trying to understand all cancers more in depth. They've studied, how is DHT levels controlled, and they're basically manipulated locally by the tissues. Right. So what I mean by that is the prostate gland will control, for want of a better word, the level of DHT in the gland itself, in the organ. And so what's in the serum doesn't really tell you much about the DHT levels. Well, it doesn't tell you very much at all about what the levels are like in the prostate gland. And if you take that with estradiol and you apply it to all the organ systems where estradiol is being made, which is pretty much all over the body, it just tells you that serum level doesn't tell you much about what the organs are doing. And actually, the organs are specifically designed to control those levels. So they'll take the testosterone and they'll make the estradiol they want to make, and they'll I don't know if the manipulate's the right word, but metabolize and break down and use what they need to use before it basically, like you said, it's just kind of leaks out into the blood. So what we pick up is essentially what's leaked out primarily. I mean, if you look at how much estradiol is contributed to by the testicles, for example, I think it's about 15%. The rest is made around the body from your testosterone. So it's quite hard to wrap your head around. I think where it might be relevant in the serum is actually more if it's low. That's probably a sign.
That would make more sense, right?
Yeah.
Yeah. If it's low in the serum, it's probably low in the tissue.
Yeah.
I would have to confirm that, but yeah, that would logically flow, in my opinion. So, and that's, I know, do you routinely check estradiol levels?
We do. Yeah. I mean, I would be happy not to, but when you use these labs, you use the labs to do home visits for your clinic.
They come bundled.
Exactly. Yeah. You use bundles. Yeah. But the beauty of that, Andrew, is that I get to see so many estradiol results, and something that it highlights to me, other than the fact that it's almost always above the normal level, is that it doesn't correlate to what we think of as high E2 symptoms, hardly at all. Right.
Yeah. That's the advantage of getting them, is you really, it really drives that point home. I don't routinely get them anymore unless a patient requests. If the patient really wants to know, who am I to say no? But we have a little talk about it. So what have you noticed then?
I've had guys who have worried about their estradiol level if it's, let's say, 10% over the lab range. And if you kind of delve into it, it's genuinely just concern over having a red beside your blood result, and thinking that estradiol is going to do bad things to them. But at the other end of the scale, I've had guys who have had estradiol levels 3 times or 4 times the upper level of normal, and they've come back to me after 6 weeks and said, Doc, I feel amazing. I've got a libido through the roof. My wife's sick of me. All of these, I feel much better in myself. And so, I think the correlation with the blood test is, yeah, I think there is a degree of body fat. I think that maybe the chunkier guys, yeah, on average, maybe do have a higher serum level of estradiol, which makes sense.
Yeah.
But I think concerns over potential symptoms, like we mentioned, things like nipple sensitivity, maybe some mood irritation. I often find that it comes down to more impaired glucose regulation. So guys who are a little bit less metabolically healthy when they start TRT.
I agree.
Anxiety, that's a big one. I.e., it's an underlying, they see the result and they worry that that's the problem, and then that kind of gets into their head, and then they continually think that's the issue, and you have to really kind of reassure those guys.
Yeah, that's a tough nut to crack sometimes, because there are guys that hyper focus on that, and it helps when I tell them that I don't even check my own estradiol levels routinely. Now I've done it in the past under certain circumstances out of curiosity. So you mentioned the body fat thing, just to share anecdotally with me. There are times in my life where I've, just for personal reasons, wanted to get really, really lean, and we're talking like 4 or 5% body fat. And it's a miserable process. I do it every few years just to prove that I can still do it. But I got labs drawn because I just wanted to see. And so my estradiol over my 12 years plus now on TRT has varied from a low of 14 to a high of 60. And that has been almost entirely as a result of my body fat percentage. Yeah. So I gained a lot of pregnancy weight when Jillian was pregnant. So I don't know what my body fat percentage was. I was probably ashamed to find out. It was probably 18 to 20%, which for me is a lot. When I was down at 4.5, my levels were down to 14, and that's with the same standard. I take 160 milligrams total per week of testosterone cypionate. So huge variation, right? And I have to admit, I felt pretty terrible when it was 14, but I'm fully willing to admit, the reason I probably felt terrible was my body fat was so low, and I had been in a calorie deficit for about 16, 17 weeks. So, I don't think like taking estradiol at that point wouldn't have made me feel better. It was just starving myself for that long that made me miserable. But the point is that number, you're right, it can fluctuate dramatically based off of body fat percentage. And I think that's what I see the most. And you can tell me if you do as well, but the guys that do have these water fluctuation issues, that develop nipple sensitivity, that develop all of these, like you mentioned, these what we call, high estradiol symptoms, there's a common theme with these guys that I see, and it's excess visceral body fat. In almost all cases. I can think of one guy that I think is just a genetic anomaly over my career that was really lean, that developed those kind of issues, but almost all the rest of them have excess body fat. So that brings up the issue that we talked about before we were on camera here, about being on an AI for the rest of your life. If let's play devil's advocate and say that you really do need to have something to control your estradiol levels, or else you develop X, Y, or Z symptoms. It's a quality of life issue, whatever. Let's just assume that. You have to ask yourself again, do you want to take an AI for the next 40 to 50 years, or would it be more beneficial for you perhaps to go from 22% body fat down to 15, which would probably move the number to the same amount, but yet give you so many more additional health benefits from a cardiovascular standpoint, just from an aesthetic standpoint? You would look good, you feel better. Which would you rather do? Let's assume that you have to get this estradiol under control. I know what I would do, and it would be, calorically restrict myself and up my cardio, and I would lower my body fat. I would choose that 99 times out of 100, rather than go on an AI for the rest of my life. And,
exactly.
And I think when you put it that way, I think guys get it a little bit better. Even the guys that really feel that you're not going to talk them out of this estrogen issue, you're not going to be able to convince them, but you can present them with an alternative way of making that number look better.
Yeah. Yeah. I mean, often if guys contact me when they first start TRT and they do get nipple sensitivity, let's say they feel like they're retaining a bit of fluid, my advice is exercise more. Exercise more. Make sure you're well hydrated. You know, plenty of fruit and veg, and it will settle with time. And you don't actually get many cases that beyond that first 2-3 months that it doesn't settle. You know,
I've never seen a guy genuinely develop true gynecomastia from TRT.
Yeah.
Again, with the exception, there's one guy that he had pre-existing gynecomastia that was apparently quite bad as a teenager. It sort of resolved in young adulthood. And then when we got him back on TRT, and he was still relatively lean, he developed, you know, an actual accumulation of tissue, which that's what gynecomastia is. It's accumulation of tissue. It's not puffiness. It's not itchiness. It's not any of these sort of transient sensations that you might have. It's actual deposition and hyperplasia or hypertrophy of existing glandular breast tissue. I can't say I've ever seen that from TRT. Now, anabolic steroids, that's a whole different ballgame. But I can't say I've ever seen it.
The line I would say to most guys, or when I'm sort of, you know, when we're signing up to TRT and consenting, is it would be extremely unusual to get gynecomastia from TRT unless you've already had it. So it can flare up pre-existing gyno. But I think you did a video on gyno, didn't you? Where you
a while ago.
Gyno is kind of like a balance between inhibitory hormones and excitatory hormones, and it's not just about estradiol. There's several other sort of, you know, it's a sort of seesaw effect, isn't it? And actually, what it seems like, I can't remember if this is what you mentioned in the video, was that it's actually big fluctuations as well. So I think part of the management of these high E2 symptoms often would involve, and it's not necessarily the estradiol we're trying to tackle with this, but more frequent administration of your treatment. So, you know, this, if you're on a weekly dose and you're complaining of these issues, split that up. I mean, even go to daily, even try the cream. You know, all of these things will stop these big fluctuations in free T, which will stop the metabolites, you know, E2 and DHT being formed in sort of fluctuating fashion. You get yourself onto a nice steady level, allow the body to find its own homeostasis. That's often the trick, obviously.
I couldn't agree more. Yeah, exactly. So it's, you know, the long-term answer is maybe not an AI. It's, as I mentioned, body fat reduction, and then, you know, adjustment of your protocol. Maybe you're just on a poor protocol. There and that, again, you know, that is a far more rational approach to managing your quote E2 symptoms.
Well, it's gonna be ultimately healthier, like you said about the body fat. Obviously, that's healthier, but also if your body is complaining of or showing signs of fluctuations or not liking the hormonal plethora that you're giving it, splitting it up is, you know, logically it's going to be healthier for you long time anyway, isn't it?
I think so.
If you can do once a week and feel great and have no issues, perfect. But it makes sense to split it up nicely if there's issues arising. That, and the other thing I'll always mention, you know, I don't like this one, is HCG. You know,
we should mention that.
So HCG, I think, is often, because I've had guys who've complained of, you know, query, I've got high E2 symptoms, when I've said, what about stopping the HCG? You know, they don't need it for fertility. They want it for, you know, shrinkage.
Right.
They stop HCG for a couple of weeks and they're like, yep, that was it. Feel great. Feel good again.
Yeah.
You know?
And maybe it wasn't the estradiol so much. I totally agree. Dave Lee talks about that quite a bit. And, you know, the HCG is not a naturally occurring substance in a male body. I love how he says it's not LH. It is not LH. It's an LH analog. And so when you're giving it in these large boluses, which is typically how it's given, although some guys do successfully microdose it, you're having a surge in this unnatural substance that's in your body. And you know, you and I have both been on HCG for fertility reasons. I had kind of a neutral experience with it, meaning I didn't necessarily feel much better. I didn't feel worse, but you had you felt terrible on it, right?
Then the stars have aligned, so I might try it again.
Yeah.
The joys. Yeah.
Yeah. Lucky you. Right?
Well, yeah.
So,
But again, with the HCG as well, if you need it, I think there's logic to saying microdose that as well and see if that's any better. Because
sure.
instead of taking 1,000 IUs twice a week, if maybe it's some sort of quasi fertility protocol with alongside some FSH, you might want to split that up daily. That might be better for how you feel as well. But if you don't need it, knock it on the head and see if you feel any better.
It's like with all medicines, minimum effective dose.
Yeah.
Whether I'm in the ER and I've got somebody on a diltiazem drip, or whether it's testosterone or HCG, whatever the case is, it's minimum effective dose for sure.
Yeah.
So
that comes into the testosterone talk as well. As I think sometimes you see or hear of people doing sports TRT or TRT plus,
right?
And they'll say,
I don't know what that is.
Yeah. I need a bit of an AI to just control my estrogen. And actually, the truth there is that's not really TRT. That's a little bit of a cycle or something. And basically, if you're giving yourself lots of testosterone, naturally you're going to have a fair amount of estradiol. Although it does top out, doesn't it? They've done studies where
it saturates.
Your aromatase enzyme is saturated. But the other thing to consider if you feel like you're having high estrogen symptoms is look at your dose. You might be underdosed in testosterone, you might be overdoing it with testosterone, where your body just doesn't, we do all have tolerance levels of androgens as well.
Absolutely.
If I go, I don't feel better at 1,500 than I do at 900. So using your units, I prefer to be kind of the upper end of the normal range, to be fair.
Yeah. Yep.
If I go higher, I don't like it. So
that's where I feel best as well. Sport, that whole, it's not really what we're talking about here.
Yeah.
And, it's the bodybuilding world is entirely different. And that might be part of where some of these misconceptions about estradiol, I think where they originated from was the bodybuilding world. If you are a competitive bodybuilder and you're using 1,000 milligrams of testosterone a week, and certainly if you're pre-contest, for aesthetic reasons, there may be an indication to use an AI, but that is not improving your health. That's actually making it markedly worse. But I think all those guys and gals that do that, I think they understand that they're using the AI to manage fluid retention is my understanding of it. And they're using it to to look harder on stage for a given event. And they feel like they need to have, and then they probably do. I can imagine that they're, when you're on a gram of estradiol a week, you're going to have fairly high tissue levels of estradiol. But for health and longevity, that's a different animal entirely.
Yeah, exactly. I think, but even the bodybuilding world, to touch upon them as well, is that they've really reduced their use of AIs. I speak to these guys weekly.
I think you're right. Yeah. I've heard Ben Mikulski talk about that. Where he regrets using AIs to a certain extent, because I think he understands that he damaged himself to a certain extent. All those guys have damaged themselves by using those drugs. So I think at least in the off season, we should have Vigorous Steve come on and correct us about this. But my understanding is at least in the off season, they're trying to not use those as much as perhaps as they used to. That's kind of outside of my world, but absolutely. Yeah.
But think about it logically as well. It makes sense in terms of injury risk as well. And like you said about actual long-term fat loss as well. So I think they've kind of come on board with certainly minimal use, like you said, is what they're looking at now. Yeah.
So I wonder, so here's a question I'll just throw out to you. I mean, is there ever a reason to check an estradiol level on a man who's on TRT, let's say?
I don't think.
Just throw that out there hypothetically.
Yeah. Personally, I would be happy if it was taken out of our lab markers. I would be perfectly happy with that. I don't think I would necessarily come across an area, a chat where I would say, oh, no, we need to check an estradiol. I don't know. I don't know if you'd ever say never. I don't know really.
Right.
It's like I never check DHT levels.
Right.
Do you know what I mean?
Right.
So
Right.
you know, I never check them because I'm not really fussed about them. I'm looking at your general health and your testosterone levels and trying to work out what way we go.
Yeah.
So what do you think? Would there be a scenario where you think you'd check it?
Well, first I'll say, you know, anyone who's listening to this, please, if you can think of a good reason, let us know. Put it in the comments, because I always like to hear these comments, especially if we have any physicians or other medical providers. If you check estradiol levels, maybe just a quick blurb about why you do it and what you do with that information. Because I was always trained in medical school and residency, and this obviously is not true in real life practice, but most of the time, and when you order a test, it should be something called it should be a decision node, meaning that the outcome of that test is going to change your management of the patient. So, you know, I do a CAT scan on you and you've got an enlarged inflamed appendix, or you don't. Well, if you do, you're going to the operating room. And if you don't, well, we'll look elsewhere. I'll send you home, you know, so that, you know, so you're the way that I disposition you at the hospital will depend on the outcome of that test. But with an estradiol level, I don't, it's just, it's not really a decision node for me in most cases. Now, obviously outside of men's TRT, if you're dealing with a hormone sensitive cancer, then maybe you would want to check a DHT level. I don't know if we'd have to get Jordan on here to talk about whether the urologist, I don't think they even check DHT levels on prostate cancer patients. I could be wrong. But
not
with breast cancer, maybe, you may want to do it, you know, so there may be an indication in other parts of medicine, but, you know, sometimes we give endocrinologists a hard time in this world, because there's, you know, obviously some of them that maybe just don't fully grasp the potential benefits of TRT, but many of them do. But I wanted to actually read a quote from a paper written in the endocrinology literature that came out in 2019, and it's this is such a good paper. If there's any of you guys out there that are clinicians, I'll see if I can find a link to it. I just have a printed copy here, but this is it's 2019 European Society of Endocrinology, and the title of the paper is Estradiol as a Male Hormone. It's such a good paper. You guys should definitely check it out. But there's a quote here at the end that I just want to read. And this is for all of you guys that check estradiol levels. And this was written by the two endocrinologists. This guy, Mathis Grossman, MD, PhD, very well respected endocrinologist and researcher in the realm of estradiol and all things intracrine related. But here's the quote. I'm just going to read it real quick here for you guys. It says, "At present, serum E2 measurement should not be part of the routine evaluation of clinical conditions such as hypogonadism, or, this has surprised me too, or osteoporosis, because there's no evidence that E2 measurements provide clinically actionable information beyond that of circulating testosterone. Access to validated gold standard mass spectrometry E2 measurement techniques for routine clinical use is still limited for many clinicians. And measurement by immunoassay is highly inaccurate." So most labs do an immunoassay unless you can specifically request it. So measurement by immunoassay is highly inaccurate and tends to overestimate E2 at low serum concentrations present in men. Even if circulating E2 can be accurately measured, so even if you could get a good number, because E2 in men is produced locally and diffusely in aromatase-containing tissues and acts in a paracrine fashion, as you were mentioning, it is unclear to what extent serum E2 concentrations reflect sufficiency of estrogenic action in any particular tissue. So, far more eloquent than I could say it, but that sums up. That's exactly what you just said. And again, this is not Max Draper and Andrew Winge telling you guys how it is. This is in a very well-respected peer-reviewed endocrinology journal from 2019 by somebody who's a leading world expert in this field. So that's how I couldn't agree more. That's how I feel about those. And to sum that up, he's saying it's not a decision node. We really shouldn't be making clinical judgments based off of these serum levels in men with hypogonadism. So yeah, exactly. I think that's what you come across when you do it more and more over time as well, practically speaking, that
it doesn't, I mean, you just see in practice that it doesn't really tell you anything. It doesn't
Right.
really, tell, you know,
Yeah.
even
There's almost always, in my experience, and I'm sure you'll agree, in someone that comes in with these quote these E2 symptoms, there's almost always another culprit.
yeah,
And it's usually pretty obvious. It's you're a diabetic, you're pre-diabetic, you have fatty liver disease, you have hypothyroidism that's undiagnosed is obviously a big one. There's a number of different lifestyle and dietary influences there, and so there's almost always something there. So which kind of brings up my next question that I want to throw out to you and to the audience too is, I mean, how do we explain these guys that say they feel better with an AI? Because I know we're going to get the comments say, hey, I don't care what you say. I feel better when I'm on an AI. What do you, do you have any thoughts? I have a few thoughts on it. I don't know for sure, but I have some thoughts about why that is a real phenomenon. I don't think these guys are lying. I think they're being truthful. So what do you think about that?
I think it's difficult without knowing each individual scenario, but I think it can be a sign that either, so I think you get a little bit more free testosterone when you block estradiol. So it might be that these guys just feel better having a little bit more free T. I don't know if that's a potential thing. The other thing is that if the protocol is not providing a steady level, there's some argument to be said to taking a small dose of an aromatase inhibitor maybe once or twice a week would actually settle out some sort of fluctuation degree of
so if they're having a big peak,
exactly.
like take the top off that peak. Is that what you're saying? Okay.
Yeah. So some sort of stabilization of their levels, because a lot of these guys, when you hear they feel better on an AI, they're not microdosing. They're often on one or two injections a week, something like that. And my argument would be, well, why don't you just smack that down to daily and see if you can lose the AI and then work with it from there. But yeah, that was my main considerations when I've seen that online. But it's difficult without knowing the individual scenario, isn't it? But yeah, you've got some theories on it, haven't you?
Well, yeah, and I kind of touched on them a little bit. I think that underlying metabolic syndrome, high levels of visceral body fat, there are the last time I looked into this, like there's over 100 different hormones that are secreted by visceral body fat, these adipokines, and the vast majority of them at high levels are not good for you in one or more different ways. So I have a feeling that's a big contributor to it. But beneath the surface there, as time goes on, I just become more and more convinced that so much of these endocrine issues that we're seeing and these issues with both low T and estradiol are related to heavy endocrine disrupting compound exposure in our environment. So specifically, there's compounds that are found in plastics and foods or in our water supply that are xenoestrogens. And so they interact with one or more of the estradiol receptors in various different ways. They can act as agonists, antagonists, partial antagonists. And so they really muck up that whole system. And so, maybe sometimes these guys are having, quote, estrogen symptoms, but really it's not the aromatized natural estradiol that is being produced in their body that is the culprit per se, but rather it's heavy xenoestrogen exposure that is having these widespread, very poorly understood effects throughout the body. And if we can sort of decrease so maybe they feel better because their total estrogen burden, if you want to think of it that way, it is being brought down. But unfortunately it's being brought down by reducing the beneficial estrogen, the estradiol. Yeah. And in the background, we still have these xenoestrogens floating around. So some sort of I hate the word the word detox because it just sounds like so functionally, naturopathic-y. No offense to you guys out there that practice that way, but really making people aware of their potential exposures to these chemicals and doing what you can. I realize it's difficult to really limit the exposure to these things, getting rid of Teflon and plastics and not, microwaving things in plastic dishes and using, colognes and scented fragrances and soaps. And it's, obviously it's going to be impossible to completely eliminate that sort of stuff, but doing the best you can to maybe decrease that xenoestrogen load maybe at that point you can bring things under control a little bit better, in addition to dropping body fat. Because those xenoestrogens, as we know, the estradiol helps with body fat loss, but there's good data that these endocrine disrupting compounds, these xenoestrogens, actually are obesogens. So they contribute to obesity. They contribute to insulin resistance, as opposed to estradiol, this natural hormone that your body is making to benefit you, which actually helps in those areas. So I don't know. That's one of the theories I have about it, and I don't pretend to have the answer to that question. But we do, I run into guys like that they swear they feel better when they're on an AI, and there's a reason for it. I have a feeling I'm on the right track, but I'm not sure. And again, if there's any other providers out there that are listening to this, I'd love to hear your ideas on it and maybe how you manage these guys. But
the other thing to maybe mention would be that psychologically they're wedded to the AI. So
that's the other part too. Yeah.
Yeah.
The mental part of it, of course.
Yeah. And if you stop an AI, which I've done on many patients before when they've transferred over to me, is you have to warn them that they potentially go through a bit of a rocky period for the first few weeks as things stabilize. And maybe some guys have tried stopping and given up when they get something, oh God, I'm feeling that again, so I need to go back on it. So sometimes it can be a case of riding out. It's almost like when you start TRT, it's not always a clean and cut improvement over the first 6 weeks. It can be a bit of a rocky ride.
Yeah.
So maybe there's a degree of that there as well.
Sure. Yeah. And that is, it's reinforced by the fact that these guys that have these initial big fluctuations when they first start, they develop the cankles, the swollen feet and whatnot. And yeah, the estradiol, or sorry, the anastrozole, it helps it resolve. So now they're mentally, they associate the resolution of these negative symptoms with the taking of the AI. And that's where it just gets like left in their protocol into perpetuity, whereas they don't really need it anymore. And they could have maybe stopped it after 30 days.
Yeah. Yeah.
So I don't prescribe AIs at all at this point. I've been in medicine long enough to be careful about the words always and never. So I don't draw it. There may come I'm not going to say in the future there might not be a use case for it, but it would have to be, I can't even think of a scenario. It would have to be for a very limited amount of time at a very low dose, because I just feel like any of these so-called estrogen related problems usually have a different root cause and can be solved with, in other better ways. So
yeah, it often does just take time and a bit of deep diving, doesn't it? Really?
It does. And that's one of the red flags here in the States of these clinics that just hand out AIs, especially on day one. I mean, you can tell that in my opinion, that's maybe not a very thoughtful provider who has not sat down and taken a good history on a patient and taken the time to really dive deep into what's going on with their lifestyle and all the things that can cause these sort of symptoms. If you come in and do your initial visit, 30 minutes later, walk out with a prescription for, 200 milligrams of testosterone and a milligram of anastrozole twice a week, which is incredibly common. That's a red flag to me. You should probably not go to that clinic. That's my opinion on that. But that's how it's done out here. Again, our problem is different in the States. We have access to TRT. We don't always have access to good TRT clinics and good TRT providers. And whereas I think over there, I know things are getting better with Alphagenix and some of the other good clinics that are out there. It's helping, but you guys, there's a lot of untreated men. It sounds like in the UK, like there's no shortage, right?
No. I mean, I get guys who have had symptoms and even low levels on blood tests when they've had them done for 10 years and no one's ever sort of suggested TRT. It's crazy. Yeah. I think one of my messages would be, certainly the aim for guys out there, even if they're on an AI, would be ultimately it is better for you not to be on one. For your the data would suggest for your long-term health, even potentially for your symptoms, if you just trusted the process and maybe looked at the protocol, But yes, certainly starting with an AI. I mean, the mind boggles.
Right. Yeah, it's just there, there's no reason to be on an AI for 30 years. Which is kind of what these guys have signed up for. Maybe they haven't thought long term into this, but is that really what you want? Is that or is there an alternative, to being on this AI? And I know they're not terribly expensive. I mean, they're generics, but it is added cost as well. And I'm a minimalist. I just don't feel like you should be taking medications that, if there's a way for you to achieve a similar or better health benefit without a medication, maybe you should do that as opposed to a prescription drug.
Well, I think you mentioned they're not prescribing them. I'm the same. So that's quite a lot of people that we're seeing on a regular basis on TRT, and we don't see the necessity of prescribing them. So I think that's quite useful for people to know. Yeah.
Do you think the paradigm's changing a little bit with this?
I think so. Yeah. Even people who I saw online making posts maybe 5 years ago talking about, you need to balance estradiol, and you need to, and what they were kind of saying was that at this clinic, we keep it in this range.
Right. That's the argument, right? That's the argument that they have. Yeah.
Now they're kind of shifting to say, they are kind of leaning on this idea that estrogen's good for men and it's important. So I've seen a change online over the last couple of years where people are kind of shying away from talking about in range, controlling estrogen. I think that the narrative is shifting towards it's important, leave it be, just get your protocol right. I think that is it is kind of shifting that way.
I agree. Yeah, I think so too, because that's currently what I see and hear. When I look into what some other clinics are doing is, let's get you we'll shoot for getting you between 20 and 30. That seems to be a common one. And they talk about this, they say, well, the estrogen to testosterone ratio is what really matters, that sort of thing. And there's something to that. There is a proper estrogen to testosterone ratio that's likely very individual for each person. But invariably, though, what I see is that they end up overshooting, and that these guys are not walking around living it with an estradiol of 25 to 30, but they might be 25 or 30 for a couple days out of the week, but for 3 days after they take an anastrozole, they're down at 10. And we know based off of the prostate cancer studies where they would give these men estradiol or not give them estradiol. I mean, that's below the threshold where you start losing bone mineral density. Is below roughly 10 to 10. It's probably 10 to 15. You get below that and you start losing bone mineral density. So, so that's one of the recommendations, I guess. If you really feel like you need an AI and you plan on staying on an AI for the rest of your life, then okay, that's up to you. And no judgment, but maybe talk to your provider about monitoring, obviously monitoring your cardiovascular status and getting a periodic DEXA scan. And just make sure that your bone density, as the years go on, that you're not compromising your bone density, because that's not something you're going to feel. It's not something you're going to even be aware of until the day perhaps you have a fracture that you otherwise wouldn't have. So, just extra monitoring, I suppose. Would be smart if you just insist on being on one of these AIs. But yeah, that is, that's what I see is just like you do, is they want to have this sort of sweet spot. And maybe we can talk briefly before, I know we'll wrap things up here in a little bit, but where did they get this number, this like 25 to 30 or, 20 to 30, whatever it is. And, you might have some thoughts on it. My understanding is it comes from, large population data studies and databases looking at levels of men who are not on TRT. They're just sort of like baseline hormone levels. And they saw, men with these baseline estradiol levels below that had a number of adverse outcomes. And then there are men with levels that were in the higher range that had adverse outcomes. But these guys here in the middle seem to do okay. Yeah. And what I think is that it's actually they're sort of throwing the baby out with the bathwater, so to speak. It's not the estradiol, for example, that's causing whatever adverse outcome they're looking at, cardiovascular disease, cancer, etc. It's whatever the underlying process is. So if the guys with the high estradiol levels that had higher risk of clotting, that had higher cardiovascular events, it wasn't the estradiol, like you said. The estradiol, if anything, was perhaps protective. It's the underlying visceral body fat, the chronic inflammation, the dyslipidemia, the metabolic syndrome, the insulin resistance. All of that's what caused their adverse cardiac event, not the. But it's easy to fixate on that number. And then the same thing on the very far end. Who are men that naturally walk around with ultra low estradiol levels? I mean, the only time I've ever seen it is like frail cachectic cancer patients, and they have no body fat percentage. They're and they have they're obviously hypogonadal, so it's that underlying medical condition that caused their problem. It's not the low estradiol. So again, it's like throwing the baby out. Like you're focusing on the wrong thing. Yeah, and I don't know if you have what you think about. That's just sort of the way I look at it with those studies.
Absolutely. I think one of the studies that reference range did come from was heart failure, patients with heart failure.
Oh, you're right. It was one of them was heart failure. Yep.
Yeah, and it was low or high was bad and middle was okay, but it's kind of like, well, like you said, serum estradiol in a natural guy can imply, like you said, is inflammatory processes, high adipose tissue, probably impaired glucose regulation towards the higher end, and then the lower end would probably imply hypergonadal, frail, ill, whereas that doesn't really apply to us on TRT because we have
the same population, right? As we alluded to in the beginning. Yeah. So that guy that's walking around, with all of those serious medical issues, I mean, if you harken back to your GP days, and I do too, would we put that guy on an AI?
No.
And of course not, right? Like, no, we're going to put you on, you're going to be on, you're going to get on metformin. We're going to fix your diet. We're going to get you on, we probably put you on a statin. We're going to get you on an ACE inhibitor, an ARB. We're going to do all these things to address your serious metabolic issues and cardiac disease. We're going to manage your heart failure. We're not going to put you on an AI as if that's going to suddenly make your heart failure better.
Yeah. Yeah. Well, it would worsen.
It probably would worsen it, right?
Yeah.
Potentially.
I mean, there is evidence of increased risk of heart failure, I think, in women on an Estradiol long term, as we mentioned before about heart attacks and things. I think heart failure was on there as well. So, and fatty liver disease, I believe, as well. So, yeah, you would steer clear of an AI in those situations. Yeah,
that's not the first thing I would reach for in my. My decompensated heart failure patient. Yeah. Somebody give me an AI quick. I'll try that at the emergency room next time, see what happens.
Yeah.
Yeah. Well, that's, I mean, obviously there's so much to talk about here, and, there will be further discussions of estradiol on this channel for sure, because I think it's a super important, topic. And just like this paper says, estradiol is, it's a male hormone, every bit as much as a female hormone. So, and it just, I don't think it gets the press that it should. So,
yeah. I think the last thing I'd add as well is, I always like to say this to guys, is there's no other form of hormonal treatment that we initiate where we block downstream hormones. Yeah. So what I mean by that is, you don't put someone on thyroid and then block T4 to T3. You don't put women on HRT where you then block some of the estrogen metabolism.
Right.
So it's not a normal thing to consider normal, so it's not done elsewhere in medicine. So there's
That's good a great point. I think you and I in general are, I'm just, as a blanket statement, I'm generally opposed to blocking hormones in general, with the exception of obviously hormone sensitive cancers and, some of those protocols which are outside of our scope of practice. Yeah, it's the endocrine system is very delicate, and I think it's there's a bit of hubris too to think that we understand it fully, especially in the realm of neurosteroids. I mean, that's a fascinating whole area of research where there's new stuff coming out every day on that, and so we're dabbling in an area over here that may have unintended consequences in a completely different and unrelated or seemingly unrelated other part of the body when we're making these radical changes in hormonal levels. So I think you just have to be, I'm a less is more kind of guy when it comes to stuff like that, and I try not to be too clever. So there's a tendency in this hormone space to want to be clever, and to manipulate SHBG and do all these things, and let's give this, and we'll look what we do with the number, and treating our patients like physiology experiments or lab rats to try to get numbers to look better, when that's not our job. Our job is to improve the health, improve the quality of life of our patients, and hopefully extend their life and extend their quality of life as our primary purpose. So that's why they come to us. It's not to tweak, hopefully not to tweak their numbers.
Yeah, I think it's tempting as even physicians to pretend that we know more than we do about certain parts.
You got to be humble.
Yeah, exactly.
That's the thing. The longer you're in medicine, it strikes me as odd when I see physicians in certain subspecialties that seem so confident and it's borderline arrogant over stuff. And it's like, I've been doing this long enough that I've made a lot of mistakes, and you just have to be humble. You have to know what you know, but it's equally important to know that you know what you don't know. Or at least grasp the concept that there may be things that you don't know, and be humble about it. And that's why I think people that are really good at this, the Neil Rousiers of the world, and some of the other guys that have been around a little while, they'll caveat a lot of things, because they understand it's complicated, and they understand that we don't know everything at this point.
We work off what we know.
And just do the best you can.
Aim for the best outcome.
And again, it usually comes back to less is more. Less is more. So cool. Well, Max, thanks for coming on. This was a good discussion. We'll obviously I want to have you back, obviously, for multiple rounds here in the future. We'll talk about all things TRT, men's health, and I hope you guys in the audience have enjoyed this. We'll do it again.
Thank you.
All Man Medicine video and audio has been created and shared online for informational purposes only. This podcast does not constitute the practice of medicine or professional healthcare services of any kind, including the giving of medical advice. I am not your doctor. No doctor-patient relationship has been established. This content is not meant to be a substitute for professional medical advice and should not be relied upon solely for that purpose either. The only purpose of this content is to present peer-reviewed, research-backed health information for your consideration. As always, rely on the advice and guidance of your personal physician before undertaking any activity presented here, and if in doubt or not comfortable with said activity, practice discretion. Your health is your responsibility and not ours. Finally, I take conflicts of interest seriously. I accept no compensation whatsoever from any private corporations, including pharmaceutical or supplement companies. You can trust that if I recommend a medication, product, or service, it's because I genuinely believe in it and not because I'm being paid to endorse it.